Greetings. I am going to be recording for you primary and secondary immunodeficiencies. This is a lot of exciting stuff coming out of this lecture and a lot of new exciting developments and unfortunately a lot of I don't knows because especially the primary congenital immunodeficiencies, we don't know what causes them and we don't know the treatment for a lot of them. So a lot of the answers is going to simply be treat the symptoms. We don't know what causes it. So, without further ado, we'll get started. I will have to tape this in two parts. I learned my lesson the hard way. I taped it all in one, and it was too big to upload. So, now I'm taping it in two parts, but that's okay. Now I know it really well. All right, so let me get off here, and let's discuss primary congenital immunodeficiencies. So, we're going to be doing primary and secondary, and this primarily comes from Chapter 19 in your book. So, deficiencies, where can they exist in? Well, the first thing is what we call antibody synthesis. Anytime you see antibody synthesis, think B lymphocytes. Cellular immune functions. Anytime you see cellular, think T cells or T lymphocytes. And then phagocytic function. And of course, phagocytic function is when we have some type of inflammatory response. So these are the areas that deficiencies can exist in when we talk about primary immunodeficiencies. Now, we know immunodeficiencies causes a person to be unable to resist or combat potentially harmful substances. So they're very susceptible to infections, malignancies, and other diseases that come along. As far as teaching the patient with immunodeficiencies, we do have primary measures to prevent infections. Of course, number one, avoid people with infections. Injury prevention, proper nutrition, plenty of fluids, adequate rest and sleep, skin protection, making sure that we are protecting the skin with some of the immunodeficiencies. So we're trying not to do very many invasive procedures if we can avoid them. And then, of course, reporting signs of any type of infection that they have immediately. We know, like all of our blood cells that we talked about earlier, that lymphocytes develop from those stem cells in the marrow. Remember that? And some of those lymphocytes will go to the thymus. And what do they become? T lymphocytes. And some of the B cells will go to the marrow, the liver, and some other places. So remember this, antibody-mediated, you should have thought humoral B cells. Cellular cell-mediated, you should have thought T cells, T lymphocytes. So T cells directly attack and destroy foreign antigens. But T cells also secrete a substance that helps stimulate B cells and promote their immune response. So if T cells are down, B cells to a certain extent will be down. Primary immunodeficiencies congenital then. These are those resulting from either improper fetal development, genetic disorders in children. These are ones that are quite rare, usually no known or underlying medical condition that we know of. And then there's some that do not become evident until either late adolescent or adulthood. And if that's the case, we call these CVIs, common variable immunodeficiencies. Now, the major symptom with all of these are recurrent respiratory infections. Your major symptom with the primary congenital immunodeficiency is recurrent respiratory infections. Just a clue. All right. Prognosis is generally poor with these people with primary because most of these develop overwhelming fatal infections that they can't succumb to, that they do succumb to. All right, secondary immunodeficiencies. These are non-specific depression of the immune system from some interference with the immune system. So it could be drug-induced, like your steroids. Stress, we know that makes our immunity go down. Age, the very old and the very young are more at risk for stress, or more at risk for immune problems. Malnutrition affects our immunity. Radiation, surgery, and trauma. Infection, burns, diabetes, and malignancies. So all of these can have an effect upon the immune system in a secondary way. So the specific congenital primary immunodeficiency. Now, these are usually diagnosed between 3 months and 2 years of age. Why not at birth? Well, if we think about it, maternal antibodies are present, and they're present up to about 18 months. So it's going to be a while before you see them having these problems. If you'll remember back to our antibodies, IgG the giant was the only one that crossed the placenta. Well, that's the main one that affects against a lot of infections. So if you think about that, particularly bacterial. Now, IgA helps with a lot of your viral and the respiratory. So because of mom's antibodies being on board, especially if they're breastfed infants, you may not see this until 3 months to 2 years. Now, these disorders are classified according to their deficient structure. If the B cells, that would be humoral, T cells, cellular, or unfortunately, they could have a deficit of B cells and T cells both. So there's 3 main types. Number 1, the first type of primary congenital immunodeficiency is called humoral. I thought B cell, did you? Immunodeficiencies are also known as antibody-mediated. Now, with this one, we lack protection from a variety of bacterial and viral infections, particularly respiratory. Now, it can be treated. It may be treated with immune serum globulin and antibodies depending upon the type that they have. The first example that we're going to talk about under humoral is selective IgA immunodeficiency. Selective IgA, Sweet Andrea. And if you'll remember about Sweet Andrea, she lived in the respiratory, the GI, the GU, and the I. So if she lives in these spots, doesn't it make sense that you're going to have reoccurring infections of the respiratory system, the GI, the GU, and the I, if she is deficient? This affects about 1 in 600 live births. Therapy with this one is very limited to vigorous treatment with infections. So, I mean, there's only so much that you can give them, but that's what you do. You give as much antibodies as you can to help fight it, and prevention is the key. With this, the most common complication is pulmonary scarring and fibrosis from the repeated respiratory infections. Diagnosis is made when the IgA level is less than 5 milligrams per deciliter. So that's when diagnosis is made that you have selective IgA deficiency. You're going to need some major teaching to prevent infections from occurring. That will be focusing on preventing pulmonary infections and UTIs, avoiding occupations or habits that increase the exposure to inhalants or irritants. Good hand washing. Good hand washing. Oops, let me go back to this for a second. Sorry. Well, I didn't go back to previous. Okay. Another thing I want to mention with this one was selective IgA immunodeficiency. Let me let you think about this for a second. Why is selective IgA immunodeficiency not treated with exogenous immune globulin? In other words, why don't you just go in and give them an infusion of immune globulin? If you remember, immune globulin infusions are almost all primarily made up of who? IgG, the giant. So would they do any good? They're not deficient in IgG. They're deficient in IgA. So there's not even enough IgA in that to boost them up. So since they already have plenty of IgG, you would actually cause an increased chance of reactions of occurring. So infusions with immune globulin do not do the patient any good when they have selective IgA immunodeficiency. Now, another example of humoral immunodeficiency is called CVI. What did I say that stood for earlier? Common variable immunodeficiency. And these were ones that did not become evident until adolescence or adulthood. Now, these people usually develop recurrent respiratory and GI infections. And for this group, they usually get regular administration of IV or IM immune serum globulin and antibiotics. So why not? Why did these group get it and the selective IgA did not? Because the second type, CVIs, the main one that they're missing, humoral deficiency, is IgG. So in this case, immune globulin administrations will help. So what are some nursing considerations for immune globulin? Well, one of the things that you want to remember, and I don't have it on here, so make sure you make your little asterisk up here, is that you never immunize with live virus vaccines. So in other words, it would interfere with normal immune response. So do not administer a live vaccine within 3 months of giving immune globulin. Because if you give an infusion of immune globulin, then you go in and give live vaccines, that immune globulin is going to start developing antibodies to that vaccine and not helping you with other infections. So you're almost going to distract it, so to say. So never, ever do you administer live vaccines within 3 months of immune globulin. Do not mix with other meds. It is not a very compatible person. It does not play with other meds well. So do not mix. It will crystallize. IV immune globulin should be administered slowly and you should gradually increase the rate because people do tend to have reactions to it. Pre-medicate, pre meaning before. So before you give the injection, you want to make sure that you pre-medicate. Now, what are you pre-medicating with? Antihistamines, Tylenol, and these can be given before the infusion to decrease some of those potential side effects. Now, one of the things they may also have is nausea. So you may have to give them something for nausea, but fever, chills, headache, those are all common experience with patients getting immune globulin. So that's why we pre-medicate with the antihistamines and the Tylenol. You also want to monitor vital signs during and immediately following the infusion and always have epi on hand in case they do have a reaction. If signs and symptoms of anaphylactic shock occur, of course, you always stop the infusion immediately and administer the epinephrine. Pain, it can be painful at the site, so you want to monitor it for any kind of sensitization. Sometimes putting a cool cloth or something over the site where it's going in will help, or even a warm cloth. This is given, it can be given IM. If it's given IM, it's given in the deltoid or the anterolateral thigh. I was going to put up an article on immune globulin, but I think you've got enough articles to read, so I have skipped that. So these are the main things you need to know about immune globulin transfusion. The second main type of congenital primary immunodeficiency is cell-mediated. So what came into your mind? T lymphocytes or T cells, either from inadequate number or absent number of cell functions. And this one is very, very rare. An example of cell-mediated immunodeficiency is what we call Aldrich Syndrome. I also have called Aldrich Syndrome double trouble. This is a condition in which neither the thymus nor the parathyroid glands develop. Double trouble. Remember where the T lymphocytes go to mature? The thymus. So if you do not have a thymus, they have nowhere to go to mature. If you don't have your parathyroid glands, you're in trouble. On the actual thyroid, located on the back side of the thyroid, the thyroid is where the parathyroids are located. The parathyroids themselves are the ones that are responsible for calcium and making sure that your calcium stays within normal limits. B cell function is normal, but T cell is absent. Okay. Now, and again, the B cell may be slightly affected, but not much. But your T cell is just not going to be happening because there is no thymus. So why is this one usually diagnosed at birth and the other ones were waited until 3 months to 3 months or so before they were diagnosed? And the reason is because this is double trouble. Yes, we don't have a thymus, we don't have T cells, so we may have infections. But in this case, remember, we also didn't have parathyroid glands. So if we don't have calcium, we're going to get into tetany trouble. So these babies will be born with signs and symptoms of tetany. And again, that's usually what throws them into knowing that something's wrong, and then they'll start checking out other things and figure out they've got Aldrich syndrome. Some other things you may see is recurrent infections. Ears are low set and malformed. Hypocalcemic tetany due to the absence of the parathyroid glands. And treatment is with antibodies, calcium, vitamin D, and the only curative thing is a fetal thymus transplant for that part. What they will do is go in and They can take a fetus less than 14 weeks gestational age, and they can be locally implanted intramuscularly or minced together and injected intraperitoneally. And once in place, mature T cells will be produced. Without a successful transplant, prognosis of this disease is usually less than 5 years of age. So what they will do is, for diagnostic purposes, is they'll do a chest x-ray, and it will be negative for what we call the thymic shadow. Usually when you do an x-ray, you can see the thymic shadow. You would not be able to see that with someone with Aldrich syndrome. Of course, if they were to check the lab values, the T lymphocytes would be absent with normal B cells. And if they were to check the parathyroid gland, they would see a decrease in parathyroid hormone, a decrease in calcium, and an increase in phosphate, because when there's an inversal relationship between calcium and phosphate when it comes to the parathyroid gland. So calcium would be down and phosphate would be up. So those are things that would help with the diagnosis of Aldrich syndrome. Now, the third main type of congenital primary immunodeficiency is what we call combined immunodeficiencies. These involve the B cells and the T cells. Usually these are very ill children with very poor prognosis with repeated and severe infections. Years ago, there was a movie called The Boy in the Plastic Bubble with John Travolta. Yes, I'm telling my age. And he had severe combined immunodeficiency. So the example of the combined immunodeficiency is SCID, severe combined immunodeficiency, and this is when you have an absence of B and T cells. So you can imagine you don't have any antibodies to help you out. You have nothing turning the system on and off. There's absolutely nothing to help. So anything you come into contact with could possibly cost you your life. That's why they have to be in plastic bubbles. Failure to thrive is a sequence of persistent illnesses. Sepsis is common. They're going to do, as far as diagnosis, they're going to look at the history. They're going to look at the lab. Usually they've had recurrent infections from early infancy. Of course, they wouldn't have any lymphocytes. They wouldn't have any B cells, any T cells, and absence of the plasma cells in the bone marrow as well. Treatment is going to be with antibiotics, even though that's not very effective. Placing the child in protective isolation, a plastic bubble, is the best way of doing that. Histocompatible bone marrow transplants have been somewhat successful and is the only definite treatment. And usually it's from a sibling. Intravenous immune globulin can be used to help augment the humoral immunity until the transplant is performed. There is a new experimental approach for curing genetic engineering, where they're inserting a functional version of the defective or missing gene actually into the patient's own bone marrow stem cells, and that's been somewhat successful, but that's still in the developing stages. Whoops. Another example of combined immunodeficiency is what we call the WUS syndrome. This is Wiskott-Aldrich Syndrome, or WUS syndrome. It's X-linked recessive, which means that it mainly affects males. Manifestations include thrombocytopenia, so they have petechiae, they have other indications of impaired clotting abilities, especially during the neonatal period. Reoccurring infections, chronic otitis media, herpes, and sinusitis, just all kinds of things they get. And then persistent eczema or rash that appears it's particularly by a year of age. Usually it involves the AC space, the popliteal fossa, and they get a lot of cellulitis and abscesses. So these are the three main manifestations. The treatment is antibiotics, symptomatic pretty much, platelet infusions, IV immune globulin, but the only curative treatment, again, is bone marrow transplant. Without bone marrow transplant, most of your patients are going to die within the first year of life with WUS syndrome. The best donors, again, are usually parents and siblings. All right, so let's review that. There are three main types of primary immunodeficiencies. And those are, number one is the humoral. And under the humoral, we had selective IgA and CVI. Your second type is the T cell, the T cell part. And if you look under the T cell part, we had Aldrich syndrome. Then the third one is both of them, the B and the T cell, and that was the combined SCID, severe combined immunodeficiency, and the WAS, the WAS syndrome. So you do need to know those. So let's review bone marrow transplant, since that's the main way or cure for most of these primary congenital immunodeficiencies. As far as the purpose, if you think about the purpose of a bone marrow transplant, it's to provide the child and the adult with a healthy bone marrow that can produce functional blood cells. So what they will do, as always, we know there's potential for, there is a potential for immediate reactions to occur. They can be allergic reactions where you have chills, fever, and rash. Volume overload, if you're giving it too fast, and pulmonary complications like fat emboli can occur. Now, the transplanted marrow is always given intravenously. Years ago, that wasn't the case, but it is now. And then it implants itself in the bone and begins to grow. If the transplantation is successful, then you're going to get healthy bone marrow. And that healthy bone marrow that's going to make blood cells, stem cells as a result. So there's three main types of bone marrow transplants. There's autologous, which means it comes from yourself. And this is the time when you would take it when a child was like in remission. They've gotten chemo, they've wiped all the bad stuff out, they're in total remission. So you would take some of their marrow and you would put it aside for when you need it when they're when they're not in remission. Then that also, if you think about it, it's going to decrease or avoid graft versus host disease. Then you have isogenic, which is from a twin, especially identical twin, and most of us do not have that luxury, but that would also avoid graft versus host disease. And allogenic, which is what most of us get it from, is usually from a sibling, parent, or donor. And this is someone who has compatible HLA typing. We talked about that earlier. So what are the phases of a bone marrow transplant? Well, the initial phase is called conditioning, and conditioning involves a 7 to 10 day period during which that child is receiving very high lethal doses of chemo and radiation. And then what you're doing is preparing the body to accept this new healthy bone marrow. Why? Because you're going to be harvesting. What are you going to be harvesting? A new healthy marrow. So the child is going to be without immunity up here for about 10 days. And then after transplantation, and then remember what that's called, pancytopenia, when you have no red cells, no white cells, and no platelets. Well, it takes about 10 to 20 days before the donor cells begin to proliferate and mature. So we're still going to keep them in some heavy isolation while this is harvesting. This period is most critical where we put them in strict isolation in a special unit. Then you have your post bone marrow transplant, and this is after the harvesting period, and you're watching for signs of rejection and seeing how well that you're doing during the harvesting period. Now, during the harvesting period, I kind of think of this like your garden. So if you were going out and getting a garden ready, you would first condition the ground, wouldn't you? You'd get your tiller out, you'd get all the weeds out, you'd mow everything down. Then once you planted everything, what are you going to do? You're going to plant your plant. You're going to put Miracle-Gro on it. You're going to give it water. You may put mulch on it, and you're going to baby it during that time trying to get it to grow, aren't you? And then you're going to sit back and watch. But unfortunately, sometimes no matter how well you plant your garden, it don't do well, does it? They die. And some people have a better thumb, just like some people accept transplants better than others. So I kind of use it as the analogy of growing a garden. Complications of bone marrow transplant, acute complication of graft versus host disease if it occurs within the first 100 days. It can also occur after that time, and then at that point it is considered chronic. But the things you're looking for graft versus host disease signs and symptoms wise is a papular rash on the hands and feet, and it will actually start peeling and sloughing off. Nausea, vomiting, and diarrhea. Those are all main signs and symptoms of graft versus host disease. Treatment for that, before I let you go here, is corticosteroids is the main thing, and you don't ever want to stop those abruptly. Remember the normal signs and symptoms with corticosteroids. They suppress your immune system. They cause dry and stretch marks. They increase your blood sugar. So even though they're good for some things, decreasing inflammation and help with autoimmunity, they also cause other issues. So you really want to provide supportive care to these patients who've received a bone marrow transplant. You want to prevent infections, control bleeding, maintain adequate nutrition, hydration, and monitor for signs of rejection, and make sure you're providing plenty of support. Some children survive up to 10 years after successful bone marrow transplant, particularly for SCID and West syndrome. And during that time, until this decision is made, they're going to need a lot of emotional support. Can you imagine being in a bubble until you get a transplant? All right, the last thing I'll talk about, and then we will cut this recording and go to the part 2, is xenotransplants. And these are organ transplants from animals. Such animal to human procedures have been around for lots of years, and we've been doing experimental issues with these for 40 years or so. We remember back in '96, the FDA researchers at the University of California injected an AIDS patient with a baboon marrow, and they were hoping that the baboon marrow, which is resistant to HIV and a source of immune cells, would provide a better replacement for that patient's damaged immune system. It did not work out well, so they cut that study. Of all the animals, they say that baboons and pigs are the most favored donors. Baboons are genetically close to humans, so they're most often used for initial experiments. They did 6 baboon kidneys in 1964, a baboon heart in that baby in 1984, and then 2 baboon livers in '92. It says, although all the patients died within weeks of their operation, they did not die of organ rejection. Rather, they died of infections common to patients on immunosuppressive drugs. It did go on to say in this article that one drawback to using baboons is they harbor many viruses. They do say for long-term use, pigs are a better choice. Pig organs have been transplanted to humans several times. In '92, 2 women received pig liver transplants as bridges until their livers got delivered, and they both made it. So that's just one of the things they are looking at in the future, using more and more xenotransplants. All righty, we're to secondary immunodeficiency, so that ends part 1. I'll pick up here on part 2. Thank you very much.